Débora Peretti has a bachelor and master's in theoretical physics and a PhD in medical imaging, focusing on PET methodological analysis. She is currently a postdoctoral fellow at the University of Geneva, working mostly with clinical PET datasets from Alzheimer's disease.
So good morning, everyone. Thank you all for staying till the last talk. And I'm Débora Peretti, and I'm going to talk about connectivity as a biomarker. So are we there yet? So brain connectivity, and I'm going to focus this talk in molecular imaging, so we're going to switch to PET now. Brain connectivity in molecular imaging is something that has been done for years already. So these were the first papers that we could find in 1984 that were using PET imaging to assess molecular connectivity. And since then, the field has evolved a lot. We have seen several different networks that have been identified for a lot of different disorders, pathologies, but also in healthy brains. So here we have several examples of, we have some, where's the mouse? Here. So here we have some controls, we have mild cognitive impairment, we have Alzheimer's disease patients, we have a spinocerebellar ataxia type 3, and Parkinson's disease. But we also have some pathology networks here with amyloid beta and tau pathology for Alzheimer's disease. So knowing all these networks that have been identified, what are the potential applications that we have seen so far that have been published for molecular connectivity for clinical practice? And we have seen the early detection and prediction of symptom onset, assessing disease progression, differential diagnosis, guiding selection of participants in clinical trials, and assessment of treatment responses. And most importantly, also placebo response networks, because we know that some patients are receiving placebo or they are having some kind of placebo effects. And some of these networks have been identified using molecular imaging, brain connectivity based on molecular imaging. And right now I would just like to do a little bit of shameless advertising, because I have a poster that will be showing a little bit of this assessing disease progression and differential diagnosis in Alzheimer's disease. So this is where you can find me this afternoon and tomorrow. So knowing all of this, why are we not using it then as a biomarker? So changing a little bit, so from a clinical perspective, what do a clinician needs in the clinical practice so that they can use this as a biomarker? First of all, of course, is a reliable measurement. They need something that they can trust. But most importantly of all is that what they need is a simple and integrated software. They need something that is going to just pick up the image directly from the hospital system and is going to assess the image directly. They don't want to do a lot of clicking, a lot of things that is going to give them a lot of trouble. It's going to take a lot of time, that they're going to have to read long reports or anything. They want something simple and easy. They also need to know what a healthy patient is, or a healthy control would be, so that what they are saying, they need to understand what's the difference. But most important of all, what's needed is a single subject metric. Molecular connectivity so far is mostly done group-based, and that is an issue when bringing to clinical practice. We have one single subject that comes to the clinic, and they want to know, the doctor wants to do an assessment. So what good is it to put it in a big group of individuals and say, yeah, it's not an outlier? No, what we need to do is have a single metric for this individual. So I'm going to focus my talk on scale subprofile modeling using principal component analysis, and I'm grateful that Chris already introduced it, so I don't have to go through everything. And basically, what we do is we take a group of controls, we take a group of patients, and we put them through this code that's going to do a normalization step. It's going to extract the principal components, and then it's going to combine the components in a way that best separate your groups of controls and patients. In this example, I introduced some healthy controls and Alzheimer's disease patients, and then in the end, I generated a characteristic disease pattern for Alzheimer's disease. And the good thing about this methodology is that it gives every single subject that I inputted in the model a score that gives an expression of how much this patient is expressing this disease pattern. And then this pattern that has already been produced can be used to test a new subject. You have a new patient coming to the clinic, you don't have to redo all the pattern or everything. You can just take this patient and check the score and see how much of the disease the patient is showing. And this approach has already been used for several different disorders and several different radio tracers. So here we have first Parkinson's disease, which was the main application for this technique. We have here a pattern of Alzheimer's disease. We have spinocerebellar ataxia type 3 and type 36 based on FDG PET, so glucose consumption. And we can see how much of hyper or hypofunction we are observing in the patients. But here also on the bottom left, you also have a pathology image of amyloid pathology. And here you have some tau pathology in Alzheimer's disease, but tau pathology in frontotemporal dementia as well. So right now I'm going to focus again on another tiny subset, which is in Parkinson's disease. So this technique was firstly published for voxel-based, based on Parkinson's disease patient, and most of the studies that have been published using it are also done using Parkinson's disease. So we know that methodology is sound, we've seen the math, it has been done over and over again. So it works. And this pattern has already been validated also with test-retest data. So we have patients that come one day and then they come again next day in the clinic, and we've seen the same patterns again and the same pattern expression again and again. So we know it is a reliable measurement. The pattern has also been validated across centers. So these are different patients, different centers, different scanners, different protocols of image acquisition, and we've seen the pattern again and again. We have similar patterns all over the centers. And most important of all, we are trying to move in clinical practice from a clinical perspective of patients to a biomarker-based perspective, so that we don't have to rely on the experience of the clinicians for assessing a single patient. And the latest guidelines for Parkinson's disease are actually endorsing the use of the metabolic pattern for assessing Parkinson's disease in patients. So knowing all of this, I ask you all, are we there yet? So we know all this, we've seen it all, it's been endorsed, so can we use it? And then we come again to methodological issues. And despite everything that has already been presented by the previous speakers, we have seen that SSMPCA is also sensitive to acquisition protocols. So here on the bottom left, you have this graph that shows different scores. So we have 5 healthy controls, 5 pre-symptomatic Parkinson's disease patients, and 5 Parkinson's disease patients. And the same image has been reconstructed with several different types of acquisition protocols, reconstruction protocols. And we can see that there is a huge variability in the scores that were given to these patients. And here on the right, you have a plot that shows a study that the patients that were scanned using different scanners. And you can see also that even like within scanners, you have a lot of differences between the scores. And this is a study that took one single pattern based in a cohort in the States. And then it took 4 different cohorts from 3 different centers with 4 different inclusion criteria for the patients. And you see the variety of the scores all across the samples. So what we take from this is that basically every center is going to need their own pattern. And not only their own pattern, but their own sets of controls that might change a little bit how the pattern is going to be created. So to bring molecular connectivity as a biomarker in clinical practice, what are we going to do? What we're going to need? First thing that we need is validation of the networks. We need different centers, we need test-retest, we need to do it over and over again, but not trying to find, as Shimon said, not trying to improve the pattern, but at least see that it's stable. Then we are going to need big sets of healthy controls. And the biggest problem with this is that if you're doing clinical practice, if you have a clinical center, not a research center, you're not going to have a lot of controls, because you're not going to recommend a healthy person to go through a PET examination just to increase your database. So we're going to need harmonization in acquisition and processing protocols, so that in the end we can use large sets of healthy controls all over the same sets all over different centers. And this is an example from Manas Chakari that they are trying to introduce centiloid measures in clinical practice. And for that, they had to do some kind of harmonization of amyloid imaging. And they are showing here that they actually managed to harmonize the scans across different centers and different scanners and acquisition protocols. Then we need more single subject metrics. And I am a huge fan of this work from Tommaso Volpi and Alessandra Bertoldo that is using more dynamic imaging. So PET in clinical practice is mostly done static. So we have one patient, one image. And me as a physicist who likes modeling, I'm a huge fan of dynamic imaging. But of course, in clinical practice, we cannot take 1-2 hours of the scanner just to scan one patient. So we need to adapt more imaging protocols so that we can have more data. In our clinical center in Geneva, we are doing the dual phase imaging protocol. So we have patients that come for the clinic and they have one scan, then they are injected already inside the scanner, they have one image, they are taken out, and then they wait 70 minutes, then they're brought back to the scanner, and they have a second image. And those images can also be reconstructed dynamically with no additional burden for the patients. And with that, we can have a full dynamic image, not a full dynamic image, but a dual phase dynamic image that can be used for modeling. So this type of adapted protocols might be the solution for getting there. So my opinion is always get more dynamic PET imaging so that we can evolve more this use of molecular connectivity as a biomarker in clinical practice. And with all that, I would like to thank you all for your attention, and I would like to remind you all that we have the Molecular Connectivity Working Group that is trying to push forward this field of studying molecular connectivity, and just my poster is going to be there if you want to check.
Thanks a lot, Débora. Are there any questions? Okay. If not, if somebody wants to stay a couple more minutes, we could reopen the questions for all the speakers. So if you have any questions for any speakers, you can. Okay, then, okay, everybody's heading to the keynote. So if you want to speak to the speakers, well, just meet us here. You know where to find us. So thanks a lot.
Thanks. Thank you all for coming, and have a nice symposium, rest of the day.
I have a question for you, but also very